Hello. Hi. Well, our moderator isn't here, so we're going to do this ourselves. So bear with us. I think everything will be fine. We're going to have 3 presentations. We are from St. Thomas. We're going first, then Brett, and then Lindsay is going to go afterwards, and then the questions at the end. Okay. So, my name is Joe Mai. I work in family medicine. I've been doing it for over 20 years, surprisingly. The last 10 has been in mental health and addictions, and I have a keen interest in it. I go by he, him. This is my colleague Shelley West. She is a nurse who works quite closely with me at the Central CHC in St. Thomas, and she has also been working in this field for over 10 years. I want to acknowledge that in St. Thomas, we are on the traditional territories of the Haudenosaunee, the Anishinaabe, and the Adirondack and Mississauga peoples. Shelley, do you want to start us off?
Amid an overdose crisis, which continues to worsen, we are here to provide a message of hope. We will share an approach to care that has resulted in positive outcomes for all our clients and the community. The work that we do has allowed clients to be in positions to make better choices for themselves. And the other agencies in St. Thomas, which are fantastic, by the way, have been great partners and have worked collaboratively to provide access to services that our clients need to improve their lives. If time permits, I'd love to share a bunch of the stories that I have from our clients. They've been really giving in writing things down for us. But for now, I will turn it over to Dr. Mai.
Thank you. Okay, thanks, Shelley. Appreciate that. So we are here to talk about homelessness, of course. It's a complex issue. I've heard some really great things. I like the attitudes of everyone here, and I think it's really positive that we can learn from each other and carry those attitudes forward. What I'm here to talk about specifically is one of the major factors that affect homelessness, and that's substance abuse and addiction. Am I echoing? It sounds like I'm echoing. Is it okay? Okay. So, as you know, substance abuse and addiction is not it's very complex too, and it's not as well known as it should be. There's lots of information out there, but the general public, I would say, on average, has a lot of misconceptions and wrong perceptions that are quite unhelpful and even downright harmful to clients who deal with it. We started our program about 4 years ago, just before COVID really took off, and I was in a family practice. I came to the community health center because I wanted to do something different. It was a type of system where we could do wraparound care, spend more time with the clients. I had already been doing some addiction work in my family practice, and I really enjoyed it. And so we kind of evolved from there. We kind of took what we learned from our clients and moved forward. And surprisingly, we have come up with something that works quite well, and we want to share it because as a result, our community, St. Thomas, has done really well in terms of reducing homelessness, and Shelley's going to present some data to you, as well as some other statistics that have been quite remarkable and not something we expected when we started out doing this. So there are some key insights that I've learned along the way, and I want to start with them first. So addiction and substance abuse is a chronic disease. And maybe I'm speaking to the choir, but I just want to say that's really important. Just like diabetes or hypertension, it is a condition that needs ongoing treatment and care to optimize a person's health, okay? The second thing is there are lots of deeper issues that are there that lead to addiction. Again, you probably already know this, but it's not that someone is making a choice because they're morally weak or they want to enjoy euphoria and that's why they use the drugs. I look at it like an onion. The outer layer, the visible layer, is the addiction that everyone sees and that we judge or try to help. But what's underneath that is the mental health and the untreated conditions that they have, including social issues that haven't been dealt with. And below that even, the deeper layer is the trauma, which we really understand as the driver for a lot of the behaviors that people have to survive. And the self-medication with drugs, opioids, in a lot of cases, is a way for people to cope and survive. And understanding that was very important for me in terms of developing how we would treat our patients, because without treating the substance abuse, I found it very difficult to really get to the heart of the matter, even just getting to the mental health. They had schizophrenia, they had bipolar, simple depression, anxiety, ASD. It was hard to get them to be clear about what their symptoms were, to accept treatment, to be consistent and follow through with treatment. And so I was looking around and I was thinking, why can't we treat their addiction better? I had already been working with Suboxone at that time, and Suboxone is a great medication. So it's, I don't have time to go into all the pharmacology today, but a simple summary is that it is a partial agonist that works on the opioid receptor, just like all the other opioids. But when it binds, it only releases a small amount of dopamine, so that the reward center is only mildly stimulated and not fully stimulated. And that's really important in addiction, because our bodies have evolved to be very good at avoiding the extremes. So, when we have a lot of stimulation from one thing, it downregulates so that, we don't get overstimulated. And if we don't get enough something, it is very good at kind of increasing sensitivity. So buprenorphine, the drug, comes in the form of Suboxone and Sublocade. Suboxone is the under the tongue tablet form, or there's now a film that's covered in Ontario and maybe in other provinces too, that dissolves. It works great because it binds very well to the receptors, and so it lasts a long time, and it also is very resistant to other opioids taking its place. So if someone has chosen treatment with the under the tongue method for 24 hours, it's very hard for them to overdose or even get euphoria from other drugs, which is a very helpful thing when you're dealing with this psychological part of the addiction, because when your body has been exposed to that high dopamine release, that's what it wants. Physically, if you don't have it, you have withdrawal, which we all know, which is very distressing. But psychologically, having that memory is very, very triggering for people. When they look at the drug, it causes a lot of the dopamine to be released. So if you take Suboxone or Sublocade, the buprenorphine, it retrains your brain so that once it's in your system, you take a drug, you don't get the same response. The next time you look at the drug, it isn't as much of a trigger for you. So that is wonderful. The big game changer I found was that Sublocade, which is the injectable version of it, which lasts 30 days, makes a huge difference, because it's the same drug, but you inject it under the skin. Sorry, I should have said, we don't have much time. I have slides. I'm not going to use them really, because you can access them later. I just want to have a chance to speak to you because I have 20 minutes. So I could speak all day, but I have 20 minutes, so let's just do that. But I can show you one thing though. There, this slide you might like. Buprenorphine. So that is the medication, a full agonist up there. Fentanyl, hydromorphone. You have a low dose, you don't get much effect. As you increase the dose, it gets exponentially stronger, and then it tapers off, but that level where it tapers off is far beyond the level of tolerance, and people overdose. An antagonist like naloxone, as you would expect, you take it, you don't have that dopamine release. In fact, it prevents other opioids from working, and then the drug I'm talking about, buprenorphine, it has a limit. So it does stimulate that dopamine receptor, but to a point, and then it just stops doing it, which is really important because it first of all, is very good at preventing withdrawal. And as we know, withdrawal is one of the key contributors to people maintaining their addiction, right? When you're feeling the horrible, sweats, chills, body aches, joint aches, diarrhea, that's a strong reason to take something just to relieve that. And then, like I said, there's the psychological effect on top of that. So buprenorphine is really good at preventing withdrawal, but the other very important thing is because it binds so strongly to the receptor, overdose is almost impossible. And we'll share the data. So all of our clients who are on Sublocade, and we've had over 200 in the last 4 years, we've had 0 overdoses. And these are clients who are the most vulnerable in our community. They are homeless, they live in the shelter, they live in encampments, and the ones that have accepted treatment for us, they have consistently told us that, I was really sedated one time, and they thought I was overdosing, but I didn't. I woke up, and no one has died from that. And we have statistics about ICU admissions and so forth too. So Sublocade is a real game changer, and you would think, wow, what a great medication. Why wouldn't everyone just accept this? Why isn't this widespread? Why are we even bothering with methadone or safer supply or, naltrexone? The reason is that it has the drawback of not allowing you to have that euphoric feeling. And for some people, that is a big deal because they use opioids as a way to escape their trauma. It's a way of self-medicating. So we looked into it further and thought, well, what can we do to get people to accept this treatment? And because, from all the literature I read, it was very helpful. Why wouldn't people want to do this? So anyway, we delved deeply and we realized there's a lot of barriers to any type of addiction treatment. So from frequent visits to, the undignified urine testing to, disrespectful treatment. What's the other thing? And the inflexible rules. That's the other thing. So we said, why don't we try to reduce some of these things and see what happens? So I realized quite early on that urine testing was pointless. Really, the only reason I ever do urine testing is if a patient wants it and they want to know what's in the substances that they use, or they need it to present to Children's Aid or whatever to show that they're not using, right? So that was a big deal for a lot of my clients. We gained their trust. We started to kind of, give them good primary care while they were kind of hemming and hawing. And then finally, some of our key members accepted Sublocade. They did really well, and then the word spread. The other big important thing about Sublocade is that it helps people to be more clear-headed so that they can think better, make better choices for themselves. The fact that Sublocade lasts a month is also key because people often have moments where they want treatment, they want to get better, but then there are moments where that changes. If you catch people in the moment where they want treatment, and that is part of our low barrier, we start people right away, and I develop, I have techniques that we can start them at any time. Because it can be tricky with this medication to start, but it's not something that is so hard to do, and I think all family physicians really should be able to do this and understand how to help someone right when they need it, because if they don't get their treatment now, and they say they'll come back next day, Shelley and I will tell you, 8 out of 10 times they're not going to come back. You catch them, they have the treatment for a month. Sometimes they aren't happy for the first few weeks, but almost always after the first month they see the benefits. And so, like I said, we have had many return clients, and they have spread the news to their friends. So in addition to those barriers that I mentioned, there's one other very important thing that I've done differently that I think is kind of key to how we've practiced, is that we don't expect abstinence from clients who are on Sublocade. And that's in the literature. I mean, it's very clear that, the majority of people who are on treatment, any treatment, will use illicit opioids. So judging people and, making them feel like they are doing something wrong, it doesn't help. And so what I have worked out with a lot of my clients is a different type of accountability without judgment. So you can read here, judgment can come in the form of judging content, or you can be judgmental and apply attitude to someone's actions. So that is really key, because clients, if they trust you, want you to do what's right for them. So if I am saying to them, you know, I want you to do your very best, try to limit your illicit drug use. If you do, it's no big deal. That means something to them. If I say nothing, if I give them treatment, which some of the places do, give them treatment and say, okay, you're good, you're safe, you're fine. It doesn't work. Expectations are important. I believe in accountability by oh, now you got me flustered, by keeping people to what they want. So I asked them at the beginning when they want treatment, do you want to get off drugs? Yes or no? Yes. So when they come back, I talk to them about, okay, so you use how much? They're honest about that. I say that's fine, that's understandable, but that was way less than last month. Great. I'm telling you that you wanted to be off drugs, so I want to help you in any way possible to reduce that, even if it's a matter of sending to our counselor, talking to you, whatever. But that is the key, is the accountability. And one final thing is that from there, it jumped, it has even expanded further, where not only am I okay with them using illicit drugs, I have decided to give my clients a small number of Percocets, and Percocets is important so that they can deal with their psychological tendencies, cravings that will exist for a very long time, probably beyond a year, so that they don't have to be exposed to the criminal element. They don't have to, spend their money, and they can use it for other things. So those two things have worked really well. It acts as a carrot for people who are thinking about doing it or not doing it to try it, because they get something that they want, but I am giving them something that will help in the long term, and it's worked out really well. I'll stop there. I'll let Shelley talk about the outcomes that we have had, because they were quite good.
Okay. I'm going to pick out what I'm going to say now. Of the percentage who remain homeless and residing at the inn or encampments, about 70% continue with drug use, but report that they have significantly reduced or stopped their usage of opioids. With the tainted supply of fentanyl on the streets, this is a huge win for all of us, especially them. Those that gained housing supports through Indwell, that is big in our community, are able to focus on their health and move forward with treatments and therapies. Indwell staff reported that having multiple overdoses the first week that they opened at their first building, and all residents began the Sublocade program shortly after that, within the first month, I would say, under Dr. Mai, and in the following weeks, everyone was on it. But by the end of the month, no more overdoses in the building. And to this day, it's over 2 years now that they have been there. So that's great. The ripple effect is felt everywhere in our community now. We have emergency responders, firefighters, police all telling us that, and the emergency doctors telling us that they know that the overdoses and the amount of trips to the ER and the amount of ambulance calls are decreased significantly. St. Thomas Police told us that there's a significant reduction in crime rates in 23-24, and crime severity index overall.
From 23 to.
Okay. The crime severity index overall decreased to 13.5%, and nonviolent CSI is decreased by 20% in our community. So these are all, we have a lot more stories and statistics to tell, but I think our time is up. So thank you very much.
All right, everyone. My name is Wolfson-Stofko. I'm the manager of harm reduction and health services at Homes First in Toronto. And title of the talk today is Development and Implementation of Harm Reduction and Overdose Response Best Practice in Shelter and Housing Environments. So I want to start with the land acknowledgement, and that in Toronto, working the traditional territory of many nations, including Mississaugas of the Credit, the Anishinaabe, Chippewa, Haudenosaunee, and Wendat peoples, and is now home to the many diverse First Nation, Inuit, and Métis people. Also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit and the Williams Treaty, signed with multiple Mississauga and Chippewa bands. Here in Ottawa, the conference is taking place on traditional unceded and unsurrendered territory of the Anishinaabe and Algonquin Nation. And we also acknowledge all treaty peoples and those of us who came here voluntarily, particularly forcibly displanted Africans who were brought here as part of the transatlantic slave trade. So as a very brief overview of what we're going to be discussing here, I'll give a little background on Homes First, as well as the drug war, some information on harm reduction for those unfamiliar, and some of the different strategies that we implement at our sites, as well as ones that can be more effective in certain types of environments versus others, and we'll get into that very soon. So Homes First was established in 1983 in Toronto to help serve the most in need. And as of today, we're operating 7 shelters, 2 hotels, 15 low-need supportive housing sites, and 2 high-need supportive housing sites with 24/7 supports. And as far as our shelter capacity goes, we're sheltering about 25% of Toronto's shelter capacity. So we can't start talking about harm reduction without talking about the drug war. And the first thing to understand about the drug war is it has nothing to do about the drugs. It is rooted in colonialism and racism. And this is explicitly clear if you review your history. The first drug law in Canada was the Indian Act, which forbid Indigenous people from consuming, purchasing, or selling alcohol, though this did not apply to any other settler. Similarly, in the Opium Act of 1908, which banned smokable forms of opium, which was predominantly used by East Asian immigrants, yet still permitted the production and consumption of opium-containing elixirs and tonics, which were predominantly consumed by European settlers. So again, nothing to do about the drugs. The whole purpose was to justify state-sanctioned surveillance, harassment, and violence against minority and poor communities, which we continue to see to this day. And as more and more of these drugs got banned, cartels, gangs, mafias took over the supply. And this drug prohibition strategy is the direct cause of why our illicit market is so unregulated and so unpredictable that we see today, and is the root cause of why we see so many overdose deaths happening year after year after year. So by criminalizing drugs, what we did is we forfeited our ability to regulate the market. And as a result, from the Toronto Drug Checking Service, we can see that 96% of the fentanyl samples tested in Toronto, it contains other drugs. There's a wide variety of fentanyl analogs in there, a lot of nitazines, some which are over 20 times stronger than fentanyl, and then a whole gamish of benzodiazepines, many never approved for human consumption and put in trials. And then you have tranquilizers like xylazine, which is a horse tranquilizer, which is coming into the supply pretty rapidly, along with midopidine and dexmedopidine, other tranquilizers as well. And these can be very, very sedative for folks, which put them at risk for being assaulted, robbed, sexually assaulted, etc., which just increases the harm that is coming to folks who use drugs. And then when you have all of these downs, then combined with alcohol, you're even increasing the risk further or a chance of an overdose occurring. So during COVID, 1 in 6 of opioid-related deaths in Ontario were among people experiencing homelessness, and 1 in 7 were occurring in the hotel programs. And opioid deaths among people living in shelters during the pandemic increased 250%. And unfortunately, it has not gone down that much post-pandemic. So what are some things that we can do to help reduce these harms? So that leads us to harm reduction. Harm reduction is a relatively new concept in some ways to the shelter sector, and I'm hoping everyone's jumping on board. And in a very quick definition of it is that it's a set of practical ideas and strategies aimed at reducing the negative consequences associated with drug use. And so the goal is to reduce both individual and community harm. And we can, in some examples, are syringe exchanges, safe smoking kits, methadone, buprenorphine, safer supply, compassion clubs, free DULF, and also overdose prevention sites as well, which we'll discuss later on. Very importantly, is harm reduction is backed by over 35 years of evidence in a variety of countries and settings, right? That's more than a lot of other things as well. And it's been shown collectively to reduce HIV and Hep C transmission, reduce overdose deaths, and reduce hospitalizations while increasing an uptake in health services and connecting people to treatment who want it. Harm reduction is rooted in human rights and social justice movements and supports people in making any positive change in their life. We are totally cool with baby steps. It's all good. We just want folks going in the right direction. And to be explicitly clear, harm reduction is not opposed to people going into treatment. It is not opposed to people pursuing abstinence, but they do deserve that autonomy to make these decisions for themselves and the direction that they want to take their lives and what they want to pursue to fulfill their dreams. And all in all, people can't get better if they're dead. And so we have a number of people that we want to support that, and a lot of folks who have done very well because they were able to get these supports and turn their lives around and take it in the direction that they wanted. So next I'm going to get into some harm reduction strategies that you can pretty much apply in any kind of shelter setting or supportive housing site. And these are all developed according to peer-reviewed research, best practice documents that have been put together, client consultations, and some of our discussions with our harm reduction partners that we collaborate. So one very basic one is 24/7 barrier-free access to harm reduction supplies. And so how we do this in a very cheap and effective manner is we buy these shoe racks here, 15 bucks or so. We bolt them into the walls, label each part of the rack of what kind of kit's in there, and we put the kits in, as well as intramuscular and nasal naloxone, and then we have staff refill it throughout the day. So there's always access to it. You don't have to go through staff or anything like that because a lot of stigma. So we just want people to get what they need and be able to do their thing safely. We also are we've trained all of our frontline staff in how to use naloxone and pulse oximeters. And I actually we've set it up so I get an email from HR every time we have a new frontline staff. I notify my supervisor. They go and train folks on overdose response in the first week that they're on site. And then we have mandatory refreshers every 6 months or whenever needed. If someone kind of panicked because they hadn't responded to an overdose in a while, we go and give them a refresher right away. And as well, intramuscular naloxone is best practice. You can kind of gauge the dose. It doesn't hit people as hard and cause folks into a serious withdrawal, into a very intense withdrawal. And so what we have found from really heavily promoting it and going to do training with anyone pretty much who administered nasal naloxone, sorry, that arrow moved. We saw a 129% increase in intramuscular naloxone being administered and a 60% decrease in nasal naloxone being administered. So we're going the direction that we want. We've also the pulse oximeters, aside from just telling if the person's got a heartbeat, which is all we really need to know for our purposes, also tells us how far gone the person is. If they are having a really bad overdose at 50% blood oxygen, or if it's pretty mellow and around in the high 80s, we can then respond accordingly, and in some cases just with oxygen. And so we've been training our staff pretty vigorously for the past year or so. We've got over 250 of our frontline staff trained in how to use oxygen. They've responded to 73 overdoses with it. And we're hoping by early 2025 to have all of our frontline staff trained in how to use oxygen. That includes both non-rebreather masks and bag valve masks as well. We also do we call walk-arounds. And these are done every 15 minutes at our sites to go and check the spots where people tend to use the most. So in the washrooms and in the showers and in the stairwells, because in an open dorm site, there's really not much privacy. And these are the most private places. And particularly for folks who are injecting, privacy is very key and very cherished. And so that's where we're seeing a lot of overdoses. And so we also are in the process of installing these tap tags, so kind of like a fob, where it's if we put it pretty far back, let's just say in the washroom pretty much, it ensures that the checks are getting done because the person has to tap it and we have a record of it. And so that we're making sure these checks are really being done and being done properly. We have a protocol as well that we're getting going to connect all of our clients who overdose to OAT or safer supply. So because a lot of folks that we see are not actually connected or on methadone or buprenorphine or safer supply, and those are the best strategies we have to reduce the chance of overdose and death. We also, at most of our sites, have an on-site pharmacy, so a one-stop shop without people having to leave the site to get all their medications that they need. We also have on-site primary care clinics available, as well as virtual mental health clinics, all on-site. We collaborate with our community health partners, community health center partners who provide a lot of harm reduction supports, like teaching safe use practices on how to do test shots, vein care, why it's important to rotate injection sites, et cetera. And they also provide peer witnessing for people as well. We also train all of our clients in how to use naloxone, whoever's open to it, because once they leave the site, they become first responders for their community. So the next thing I want to kind of get into here is risk environments. So this was developed by Tim Rhodes over in the UK. And in a nutshell, the definition is kind of the influence that physical environments, social norms, and societal structures have on substance use and the chance of adverse events. And essentially, we have to acknowledge that some strategies, harm reduction strategies, are going to work better in open dorm settings versus those happening in private rooms like the hotels and in supportive housing. And so here's what we've kind of found works best, and a lot of this is backed up by literature as well. So one thing is for open dorms is that there's a huge growing trend towards smoking fentanyl and a reduction in injection. And so a lot of people are using meth bubbles to smoke fent. There's a few OGs still using foil, but not super often anymore. And so we make sure the smoking area is getting checked every 15 minutes. And also we try to keep it open as long as possible during the overnights so we don't set off any smoke alarms and get fined by the fire department. And we've also been setting up these pop-up tents in the back there so that people can go out, when the weather is like not so great as well, just to provide some dignity. But the number one priority, I'd say, for harm reduction in the shelters, aside from some of the other things I mentioned before, are operating overdose prevention sites. And we are lucky enough to have one at one of our sites. This is a photo of one of the booths. For those unfamiliar, they're hygienic spaces where people can inject drugs under the supervision of trained staff, where they can respond immediately to an overdose. And this is very important because it's underappreciated that brain damage can occur very quickly once someone stops breathing. And if we're delayed in finding someone, yes, they may survive, but there's a good chance that brain damage has occurred. So we want to make sure we give people a place to do their thing. Also reduce any kind of people staying in the washrooms for too long. That creates tension and everything and aggression if you can't get to the toilet when you need it. And also for the sake of our staff too, who walk in doing their rounds and find bodies on the ground. That's not good. It's going to burn our people out, and we don't want that. And so by giving people a place to do their thing and keeping an eye on them, it can reduce that from happening, as well as reducing toilet clogs from needles and paraphernalia as well, which is a huge, adds up in costs. Some of the challenges is you got to get an exemption through Health Canada. Their operating costs as well can be a little bit burdensome, but you can collaborate with community health centers or public health agencies. And the whole political backlash right now we're seeing in Ontario is completely unjustified. Again, there's decades of data on the effectiveness of these strategies, and I will leave it at that for the moment. So Toronto Public Health operates our overdose prevention site, and the amount of days they've been there has kind of varied a bit, but they've been there for a little bit over a year. And here's what we're seeing is that 187 unique clients have come through. There have been over 1,300 injections there, almost all fentanyl. 65 overdoses have occurred. 28% were addressed solely with oxygen because they were able to catch it early. And furthermore, 83% of these overdoses were solely addressed with by staff, and no EMS calls needed to be made. And if anyone noticed the Auditor General report in Toronto for paramedic services, there were 1,200 times last year where there was no ambulance available for care. So anyone having a heart attack in a car accident, no one could go and help. So shutting down these sites is going to increase the demand further on EMS, and then people who think they're not affected by this crisis are going to be affected when their loved one is having a heart attack and there's no ambulance to come help. I wish that would be appreciated by those at Queen's Park, quite honestly. So they've also been providing a number of referrals. 15% of the clients were referred to addiction treatments. 22% got mental health referrals, 5% to primary care, and about 40% for other social services. So we are making these connections, we are building the rapport, and we are getting people what it is they need. Now, one of the big hypes that you see is they're claiming, the province is claiming there's all this crime around it. They claim there's a 113% increase in neighborhoods with overdose prevention sites, but all the public data doesn't show that. Who's surprised? So in City of Toronto, there's a 15% increase in assault. In our neighborhood, Harbourfront, we saw barely, not even a 2% increase in assault. And just for argument's sake, the neighborhood right next door, which also has a UPH&S further away, we all still didn't see a huge increase. And then in regards to robbery, there was an 8% increase in the city and a 30% decrease in our neighborhoods when the province is claiming there was a 96% increase. I don't know if it's arithmetic or what quite the deal is, but we are not getting, but they won't release how they calculate this data because no researchers, advocates, or media can replicate their claims. All right, let's move it along here now. For private rooms, like supportive housing and hotels. So one thing we've been doing a lot is individualized safety plans to try to collaborate with clients to, build rapport and get them to let us know when they're using so that we can then come and check in on them. And also if they need any other service, if they want like OAT or they want safe supply, we can hook them up and help them out. Peer spotting is another big thing too. And so we encourage everyone to use together. It doesn't, always happen, but we try. And we also have great harm reduction partners like the Safe Spot program at TNG, which does a lot of peer spotting and peer witnessing for our folks as well, so they can respond to an overdose right away. Now, the main thing I would argue is, because funds are tight, we understand that, you gotta prioritize. For places with private rooms, the best way to do this, I'd argue, is using safer supply for folks. And that's because we did try to open OPSs in the hotels, and they were barely used because people had a private room where they could do their thing, they could listen to their own music, they had essentially control of who was coming in, and it wasn't with some random staff or whatever trying to keep an eye on them. So it wasn't really getting used. So we need to learn a lesson essentially kind of from like alcohol, and that knowledge is power. When you know what it is you're using, you can then, and how much, you can tailor your use accordingly so you don't unwittingly overconsume. That's the problem right now. You have no idea what's in your baggie, and that is what's causing all these overdoses and deaths. And so there's a great study out in BC by Sloan White et al. That showed an 89% reduction in overdose deaths when compared to a controlled match sample of folks in a similar situation. This is a very effective strategy. And again, reducing the number of deaths and bodies that our staff find on site is going to prevent our staff from getting burned out, aside from just saving lives. And that's really what everyone wins with this. And so, of course, some of the challenges is with some of the funding through SUOP. A lot of the safe supply rooms didn't get renewed, but do not fret. Any NP or physician can do off-label prescribing for this, and the government really can't do much about it. We have a safer supply program running now at one of our supportive housing sites, trying to get all of our folks the support that they need. And it's so far working like rather well because a lot of people are using alone in their rooms. And if they're using this unpredictable supply, we don't know what's going to happen. So in conclusion here, harm reduction saves lives. It's undebatable. It's backed by over 35 years of research. Many of these harm reduction strategies can be implemented at any type of site that anyone's operating. And we also need to make sure we all pay attention to risk environments to make sure that we are prioritizing strategies with limited resources and funding to be the most effective that they can be. And we've all shown that a lot of our frontline staff with no formal medical training are able to administer intramuscular naloxone as well as oxygen in response to overdoses. And again, the key recommendations for open dorm sites, open up an overdose prevention site, or at the very least, some kind of peer spotting service. And for private rooms, push more towards safer supply prescribing and some informal spotting strategies where possible. Thank you all very much. Thanks.
Hello, everyone. I'm Lindsay from Sanguen Health Center. Sorry, I'm going to topple that over. I'm here with my colleagues, actually several colleagues in the room, and people from Waterloo region, Jess and Kasia and Kathy. And we're here to talk to you today about some of our services related to harm reduction in Waterloo region. And I just wanted to acknowledge, sorry.
This is how Sanguen is.
This, yes, we're very impromptu. Just acknowledging that Waterloo region is on the stolen lands of the neutral Anishinaabe and Haudenosaunee peoples, and also situated on the Haldimand Tract, the territory granted to the Six Nations. That includes 6 miles on each side of the Grand River. So for today, we just wanted to provide a brief introduction to our agency, as well as talk a little bit in depth about several of our harm reduction programs, our community health van program, our primary care bus, and ESHRI, which stands for Emergency Shelter Harm Reduction Integration Initiative. So each of my colleagues will be speaking on the intervention that they are supporting. Our objectives for today are that you have a better understanding of how harm reduction can be delivered through a mobile outreach response using non-traditional approaches, and how this might meet the needs in your community. So a little bit about Sanguen Health Center. It was established in 2008 by Dr. Chris Steingart and his wife, Michelle. Chris is in the room, so it's always fun to talk about somebody founding an agency when you're not the founder. Chris was working as an infectious disease specialist, treating hepatitis C in a hospital-based setting, and realized that in order to find people at risk of hepatitis C and provide support and treatment, a hospital-based setting was not the right way to do it. And so established a community program based on having a van and a community-based clinic, employing staff. It started with a nurse, Michelle, and some outreach staff to support people using drugs who are at risk of contracting bloodborne illnesses such as Hep C and HIV. So this is a little picture of our house, which was our initial base. We also have a site in Guelph as well. So we provide services in Waterloo region, which includes the cities of Cambridge, Kitchener, and Waterloo, as well as Guelph and throughout Wellington County as well. Since then, our agency has grown to around 150 people, and we do operate the consumption and treatment service in Kitchener as well, which unfortunately, due to new provincial legislation, is slated to close on April 1st. I'm not going to read through these, but this is just a general overview of the areas in which we work. So primary care, specialty infectious diseases care, harm reduction, mental health care, staff volunteer, and peer wellness. We try to engage as much as possible with folks with lived experience and employ amazing peers that work through our programs and help us with warm facilitation, connection, and expertise related to hepatitis C, but also to overdose prevention and primary care. And we also focus on community training. So we do training in shelter locations, we do training with businesses, municipalities, and other community agencies that support people who use drugs. Okay, and I'm gonna hand it over to Jess.
So my name is Jess, and I am grateful to be the team lead for the community health van, aka the van. I'm also a proud person with lived experience, and bear with me because that lived experience was running hard this weekend. So here we are. From July to September, we've had over 5,000 visits to the van. So we offer all sorts of things, right? Peer support, social support, nursing, harm reduction, anything we can get our hands on. And people always ask what they can donate, and I'm like, just give us anything, because I'm telling you, people on meth love everything. So, I've given out a pink flamingo in a garden before that, so I'm like, okay, sure, if you would like that. And they love it, right? And so it's incredible. So we'll give out anything. We go to 10 different stops, Monday to Thursday, so encampments, shelters, motels, places like that. This is an example of the van. So this side is where we put all of our hygiene and blankets and food, and that's where we'll have our volunteers. And the back is where we give out all of our harm reduction, where we have people with lived experience. And then we have a little shopping experience here, which is pretty incredible. It doesn't always look this amazing. If we're in a rush, sometimes those clothes go in bins. But we do try and give people as much dignity as we can on the racks and things like that. This is just an example of one of our little schedules, so if anyone's interested, I brought these. They're really handy to have, especially if you're in the region. But the most important part of the van is that lived experience piece of it. So we currently have 14 people with lived experience, and that is what makes our van so successful. And so, our people love to be shown, and they love their little pictures up here, and I love having my picture with them, and so this is just some of our members. So not only having people with lived experience is the most important part, it's actually how we support those people on our staff, right? Because you can believe that those people are the experts, but how are we showing that? And so those are the lessons that we've really learned on the van. So one of the biggest ones is to have people at all levels with lived experience. Not as much as the hierarchy, but just to look at people's capacity and where they can be at, right? And so I have lived experience, but I'm lucky at my capacity. I can work 40 hours a week. I can drive a car. But there may be some people that can only make it an hour a week, and that's okay, right? To have that flexibility. And also what we've really found is if we can hire people at the locations we're going to, then those barriers are breaking down with transportations. They already know the people, and so they see their buddies there that they live with, and so they're more likely to come to our van, right? With that flexibility, we also want to have accountability. So just give me a call. If you can't make it, just give me a call, give me a text, however that looks. And being a person with lived experience, it's amazing because I actually get calls that are truthful and honest, right? Hey, I just did a big shot. I'm too paranoid. I can't make it. And I'm like, I get it. I'm a paranoid out here too, but here we go. And so having those building and trusting relationships is incredible because it's really empowering to be able to call your boss, to be able to call your coworkers and say exactly what is going on, right? Hey, I got a warrant out. I actually can't come to the van. Hey, there's somebody looking for me. I owe them money. And so to have those incredible experiences at work really makes something special with the van. So I just love that piece of it. And then also having access to things like food and clothing for the people that work on the van, right? Maybe they don't have access to winter coats. So if we can get boots and coats and as little things as business cards. So not everybody has a cell phone, but we'll put our just main number of Sanguen and they get their business card. And I'm telling you, it is such an incredible experience for people to say, oh my God, I'm an outreach worker, here's my business card, right? So just those little pieces have really made our van really successful. And then the funnest one is that we will just do the wildest shit out there. And we try and have as much fun as possible. So we will just make shit up. We're like, it's National Sunglasses Day, whatever it is, right? We love to dress up in costumes, or it's hairdressing day or whatever, because we have to remember that people are living this every single day. And so as workers, as people doing all of this, we're tired, but it's if we can just bring them out of that just for an hour, just to dress up as a freaking nacho or give out ice cream or whatever, it just brings people out of that just for that hour to give them a smile and just say, okay, this is cool. These people want to have fun with me. And yeah, it's a good time out there. Awesome. So speaking of fun,
we have fun on the primary care bus too. My name's Kathy, and I'm the lucky outreach nurse to be part of this wonderful whole team, but also to be part of the primary care bus. And really, I think the primary care bus came about because of the hard work of the harm reduction van within our community. We launched in 2020, but prior to that, I was very lucky to partner as a nurse, not as Sanguen, as a public health nurse with the bus, along with our wonderful Sanguen nurses as well. So we were able to offer medical support, a lot of wound care. We were able to bring vaccines out, and just really met people where they were at and do medical assessments. But the huge piece that was missing was the primary care. And, I have many recollections of individuals coming up because they trusted the bus, but I knew they had to go to hospital, and that was always so difficult to try and, really coax them to go, the importance to go, even though I knew they had to wait hours to even just get possibly just oral antibiotics. So the bus was a dream of Sanguen, and Sanguen did a lot of work in the community to do a lot of education around harm reduction and why we needed this bus. So we finally launched our primary care bus in January of 2020. It actually hit the road in March of 2020, right at the start of the pandemic, and we were an official COVID assessment, testing, and vaccination center. I learned a very important skill in March when I started with Sanguen. I learned how to drive the bus, and it was actually a great time to learn that skill because nobody was on the road. So go from then to now. We are hugely busy, and our team has grown. From July to September of this year, we had 2,621 total interactions with over 1,000 total number of patient visits and medical treatments connections. And I am very privileged to work with an amazing nurse practitioner. I wish all of our team were here at this conference, and also 2 social support workers. The peer piece, having people with lived and living experience is so important, and we were lucky to hire an individual, a social support worker a year ago who has lived experience, and that has made a huge impact to our team and the work that we do in the community. It's very difficult to go through everything within 5 minutes. There's a few highlights on this slide, and I even over time thought, oh shoot, I forgot to put something else on there. But anyways, here's a few highlights. We're very busy. Our bus could be on the road 7 days a week. We have recently increased it, so we are on the road Monday to Thursday, and we've incorporated a new team on Wednesday, a physician that we work with, another nurse that actually is able to go out. We do have fixed locations that we go to, and we have the privilege of working at many of the stops with the van, which is great, there you are, because we really connect also with the peers on the van who are very good at doing soft transfers to us if people need medical support. So I put as a highlight, huge is the connection to primary care, and that has grown over the years. So we have a supply of antibiotics that we dispense from the bus. We have IM antibiotics that we give right on the bus. I'll show you pictures of the inside. Our nurse practitioner has worked really hard to connect with doing well women exams, and that's hugely increased just in the last few months, doing PAPs on the bus, being able to do birth control if somebody is wanting Nexplanon insertions, IUD removals, IUD insertions, a lot of episodic care, a lot of support just with folks with general health concerns. I don't know in your communities, but I find a lot of the people that we work with, they're getting older, and we're seeing more cardiac issues, more hypertension. So all of that can be done within the confines of our bus. And Sanguen has worked very hard to build that trust with folks in the community. STI testing and treatment. We do tons of testing. Syphilis. I'm not here to talk about syphilis, but we do blood work from the bus. We'll do if I'm doing wound care with somebody, I'll just have that conversation about other things that we do. We do testing for chlamydia, gonorrhea, urine screening, oral swabs, vaginal swabs, anal swabs, whatever anyone wants. And the nice thing is that we have treatment right from the bus as well. Hep C is very dear to my heart, and I have to mention that with Dr. Steingart in the room, but our Hep C testing and treatment has been hugely successful from the bus. We dispense treatment on a weekly basis, so I'm able to connect with folks weekly. It's just been a great experience, and just having that post-treatment follow-up and connection as well has been awesome. I'm a big promoter of vaccines, so if I'm doing wound care, I'll ask somebody if they're up to date with their tetanus. We'll talk about Pneumovax. We have COVID boosters. This month, we're partnering with public health to do RSV vaccines, Hep A, Hep B, really client-centered care. Not pushing all of this on everyone in one visit, but, meeting people where they're at and what their needs are. And the last two are really probably highlighting a lot of our social support outreach workers. Housing is a determinant of health, and it's always forefront in the work that we do. So both myself and the nurse practitioner I work with, we have been doing a lot of ODSP applications, which if anyone of you have done, it's a lot of work to do those applications, and also support with housing. Our social support with lived experience can do SPDATs, so it's just been really, really good, helping support people with ID as well. And of course, support with appointments and referrals. This is the postcard. This isn't mine. I brought a whole bunch. I brought like 200 in my backpack, but I can get them out after. But we have a postcard as well. It's not showing the Wednesday, but clients take it. They like to kind of have it on hand to know where we are. And this is just a few photos. I probably have to soon finish up here of the inside of the bus, but you can see it is a full clinic on wheels. We have a partition that closes, so we often have myself and Erica, the nurse practitioner I work with, we'll have 2 clients on the bus at once. It's rewarding work, and the big thing is that it decreases barriers for folks who need medical care and keeps people alive. Thank you.
So my name is Kasia, my pronouns are she, her, and I'm a registered nurse who works in Sanguen, not only with the ESHRI program, but with the Safe Consumption site. And I see a couple of my colleagues here as well, so just sending my love to you. I'm here to talk about the ESHRI program, which stands for the Emergency Shelter Harm Reduction Integration Initiative, a nice, easy one. And this is a collaboration between Sanguen and a couple other community partners that works to provide low barrier education opportunities to shelter and shelter adjacent organizations. Shelter adjacent organizations are more so organizations in our community that work closely within a shelter setting, but not actually being employed within a shelter. So if you have clients or supported folks in there that need your support, we provide education to them as well. Since the program began in 2023, we've engaged with 9 emergency shelters and at least 25 shelter adjacent organizations. So with this low barrier education and consultation, agencies will reach out, let us know what they need, and we are able to custom tailor design any sort of harm reduction education that your site needs. So if you have a specific one that you're looking for, we can tailor it. But the big thing that I want to push home about our program is the fact that our program isn't as amazing as it is without the folks with lived experience. Lived or living experience, and our colleagues who have it make this program incredible and provide us the opportunities to engage a bunch of participants, provide a bunch of different training topics. And when we take a peek at our responses to our program and different little educational sessions that we run, we really notice the fact that it builds capacity and it really builds confidence in the folks who are engaging in these systems. I wish I had more time to talk to you folks about it because our program is awesome. I'm not gonna lie, it's the best. So you have a copy of our presentation, you have a copy of these key takeaways, but a big piece is balancing a relationship in places where people are ready, gathering, embedding peer leadership and existence expertise in our programs, and the possibilities of working in a lot of sectors. So here's our contact information, and we wanna all thank you today for coming to our talk.
Hi, sorry, you'll have to forgive us, we're still no moderator. So we're gonna do a Q&A. If you can line up here, and then if there's any accessibility issues, please just raise your hand and either Grace or myself will keep a tab for you, okay? And unfortunately, there's no microphone, so you're just going to have to yell.
Pardon? It is. I know y'all don't have access. Yeah, it is. It's yeah, but you know.
I'm curious, Sanguen, fascinating, thank you, I only love it. The funding, I'm curious how the funding works. How are you bridging between publicly funded, like are you, the nurses, funded through Ontario Health and Social Services, and then Sanguen is its own entity, and I guess what does that mean?
We have a lot of different funding partners. So we receive base funding through the Hepatitis C Secretariat for our hepatitis C work. We have great partnerships with our region. So we are funded for our NSP program, a small amount yearly that supports the community health van. We also receive some funding that comes through what was the LIN to House of Friendship that's channeled to us for peer-related work. We rely on grants, like small grants.
How do you build that relationship with public services to get nurses in your van, in your organization?
We have a really supportive public health department that was very invested in harm reduction from the beginning.
And TELUS Health.
And TELUS Health. TELUS provided the funding for the the bus, to build the bus.
TELUS pays the bus, and you solicit funding to your organization through nurses or paid through public health?
No. We have a lot of different funders, but I can connect with you afterwards. TELUS provides some funding for nursing on the bus as well as outreach. We have funding through the region for ESHRI and for our NSP. And
Your nurses aren't affiliated with like a medical institution. Some of CCHC pays.
Yeah.
yes.
Community health centers.
Okay, so they are.
We funnel it there.
Through this.
Yeah.
Okay, they are affiliated.
With a badge.
Yep.
That was my senior premise. Thanks.
Okay.
Any more questions?
I just had one about the areas and locations that you go, because I know, like, I'm from London, Ontario, there's a similar kind of format that they've started, but the problem that they're seeing is places not allowing the van to be there. Do you have any advice in order to like, well,
Just go and you ask for forgiveness later. No. We've had some difficulties as well. Luckily, we partnered with a lot of places that have let us in, but that's just been built throughout the years. And I guess these places have seen that obviously we're needed, right, in those spaces. But there is a lot of that pushback. It really depends on what type of political people are in place, right? And so as much as we have been welcomed into spaces, just most recently we've been also been pushed out of those spaces. So,
just keep trying, don't give up.
Yeah, just keep trying and just keep building those connections with people. We also like to do like the public education. So if we get into those places and start educating people and having those conversations, and then our other partner programs that we have within our agency, like we have people that pick up like the paraphernalia and spots. So we'll kind of slip that in like, hey, we can come pick up those things, right? Anything that we can try to do to get into those spaces.
Cool,
So,
thank you.
We recently did an educational session in one of our cities, and during that we were kind of vocalizing how great the van is and how great the bus is and how it serves different communities really, really successfully. And after having that education session, we connected the people who requested it to Jess, and they were able to actually create a new van stop, or a stop that has been like increasingly successful in the past little bit. So it's, yeah, a combination.
Okay, thank you.
We have another question over here.
We work at a mobile health van at the Aboriginal Health Center in Hamilton, and we'll get the like enabler. But I would say like more people are happy to see there.
Yeah, we do talk about that as well, is because the stigma within our communities, right? It's like that drug users, the scary ones, and that it's actually like the old white dudes driving by yelling at our van that are scary, right? Like those are actually the scary people. It's not actually people using drugs.
We have a question before, sorry.
Is that a question?
Oh, no, sorry, that's person first and then you, sorry.
How did you pick the original locations that you go to?
So when I started on the van, there was already a couple of locations picked as like for the ones that I've picked throughout the years with my team. It's just really like what's been established. So if an encampment pops up, we know that we need to support the region. We try and connect with them because they're going to say they want these spots connected. When things start to close down, we know people are going to be in motels, so we'll start to go there. We try and connect with the bus as well. So where are they going and seeing people? It's just like where the most marginalized people are, and we're trying to hit as many as we can. And sometimes we have been going to places where we don't even announce those spots, right? In case there's people that they don't want to be known, smaller encampments where they don't want to be found, there's another team that goes to those spaces where they don't even announce those spaces.
Have you ever found that like you're going to certain areas and like you're not getting much like volume?
It's funny because that new one that we had just started, I was like, man, we just kept going, and you know, just recently it just picked up like that. We were seeing 1 or 2 people for honestly months, and now it's picked up. I would say that the locations that are picking up the most are Indigenous spaces, and again, that just comes with a lot of stigma and things like, right? It's hard for folks to come out and get harm reduction, and we are in a public space, so you see our van and everyone pretty much knows what you're doing out there. And so we still go and we still try and build those relationships, and that's where that piece of hiring people with lived experience, so hiring our Indigenous folks to come work on our van, that really has bridged that gap big time.
Thank you.
We have a question here.
Hi, I work at a community health center that provides harm reduction and primary care. And recently at one of our shelters where we're providing primary care, there was feedback from some clients that the harm reduction supplies and the bus and all that were triggering for them in terms of if they're trying not to use. And I'm curious if any of you have had experience with that and how you've managed it.
Yeah, it's been tough because we've had that in one of our supportive housing sites. It's one we just recently kind of acquired, and there are a number of folks who've said that some things were triggering, so it's like, all right, like we respect that, and let's see how we can make this work. So instead of like on every floor providing the skits, because again, there isn't a ton of use at that site. There's some, but not a ton. So we're like, okay, let's make it a little more discreet. Like we'll have it like in the basement, which is accessible for everyone, but just make sure it's stocked and available. So it's like, if you're going, and we planned it so it's like, if you're going to go do laundry or go to the community room down there, you're not gonna pass it. Unless you're really going to look for it and find it, like, you know, like that's not gonna be in your face. And so it's like out of respect, we're trying to like do it in that way. But you know, it's a balancing act, of course, because we don't want to limit access either.
Thanks.
Any questions?
Sorry.
Go ahead. We have that problem too, because we do our primary care outreach in the basement of our shelter. And so what we've done is we just tell people, if you want us to come and meet you out on the street down, you know, around the corner or something like that, we do that. If you want to come to the community health center, here's the hours, here's my phone number, text me when you're coming. We have our schedules set up so that we're mostly walk-in appointments. They know that I'm available at one of the community outreach organizations that provide care to people on a volunteer basis. They know that I'm available once a month at social services on check day. So all those things have all built up, so people know how to find us now. So that really helps.
In the absence of a moderator, I just wanted to thank our speakers. They did an amazing job. They're doing inspiring work. I think you'll all agree. So can I just have a round of applause?